All right, this is Chapter 17 of Pharmacology 2, Hematologic Products. So, clotting is one of the body's protective mechanisms. And if you were to look on page 345, there is actually figure 17-1, blood coagulation and clot lysis. Okay, now we're going to talk about how a clot is formed. Okay, so you have cellular damage, and this cellular damage has occurred, okay, and when this happens, thromboplastin is formed. All right, now in thromboplastin forms, and the thromboplastin causes prothrombin to become thrombin. And once you have this thrombin, it acts on fibrinogen to produce fibrin. And fibrin is a net-like substance in the blood that traps the red blood cells, the white blood cells, the platelets, and forms the matrix or the skeleton of the clot. So you have damage, you have thromboplastin formed, and this makes prothrombin become thrombin. Thrombin acts on fibrinogen to produce fibrin, and fibrin is the matrix of the blood clot. Okay? That's just the overview of clotting. Now, if we start to look at medications, we can talk about platelet inhibitors. So platelet inhibitors are the first line of drugs that are to prevent clots, okay? They prevent the development of more clots. And you'll find that these are used to prevent an MI or a stroke. They keep open arterial or venous grafts if someone's had like open heart surgery or vascular surgery to their leg. And how they work is the action is through different mechanisms. They act through different mechanisms to block the ability of the platelets to clump. So they block the ability of platelets to clump, stick, adhere, whatever you want to call it, to group together and form a platelet plug. So, for instance, aspirin. It's the drug of choice to prevent an ischemic stroke. Plavix. Patients who have MIs or who have had stents placed will also take Plavix. It's a drug of choice for post-MI or for post-stents. And then we have Agranox, which is like an extended release extended release aspirin with persantine, which is another antiplatelet. So that's kind of like a combination drug that has both of these. Now, of course, with platelet inhibitors, if you really think about what it is they're doing, there are going to be adverse effects. Patients who take these medications tend to bruise easier. Patients will tend to have bleeding gums, and often these bleeding gums are one of the first signs of an overdose or too high a dose. And these patients can have excessive and sudden bleeding. Even a routine cut, if it's bleeding, can go for more than, if it goes for more than 10 minutes, which does happen with these sometimes, these patients actually end up needing to go to the ER for treatment. Okay, so excessive bleeding, bruising, bleeding gums. All right, so interactions with other medications. Well, as you can imagine, platelet inhibitors that are taken with any other sort of medications that alter the coagulation process put the patient at risk for excessive bleeding. Okay? And a lot of these platelet inhibitors can interact with antacids, cimetidine, digoxin, and theophylline. So patients have to know, what their medications are when they are prescribed a platelet inhibitor. Now, there's 5 categories, all right, of anticoagulants and direct thrombin inhibitors. So the goal of these medications, all these guys in one big group, are to prevent formation of clots by interfering with the clotting mechanism. okay, and thus increasing how long it takes for blood to clot. So what we try to do is we just try to discourage the blood from clotting and making it a longer process, okay? So the first one that we use, or we talk about, is heparin. So heparin will stop the formation of clots, okay? It increases the antithrombin 3 on several other coagulation factors to slow new clot development. Now, with heparin, and I think we did cover this in Med-Surg, it is the PTT is the lab result we follow to see exactly what somebody's heparin levels are. Okay, so when heparin is used to prevent clots, or excuse me, to stop the formation of clots, it's very often used in an acute setting as an IV medication. Now the next one we have is Coumadin. And Coumadin limits the formation of blood coagulation factors 2, 7, 9, and 10. And it interferes with vitamin K. So for Coumadin, the blood level that we follow is the PT. Okay? We follow the PT and the INR. And this is different from the PTT, the PT and the INR. Okay, it's the prothrombin time and international normalized ratio. Not that you'll probably ever utter those words once you've graduated. But PT and INR. A Coumadin patient normally wants their PT-INR to be like 2 to 3. Whereas people who don't have clotting issues and aren't taking Coumadin, it's usually less than 1.1. So as you can see, the medication raises the amount of time that it takes for blood to clot. Okay. One thing about Coumadin is that patients need to avoid food with vitamin K, because vitamin K is actually the antidote. So if somebody was to take an overdose of Coumadin, accidentally or whatever, the antidote is vitamin K. So you need these patients to avoid foods that are high in vitamin K, and that's things like kale, spinach, broccoli, asparagus, the leafy green vegetables. Okay, now the next category of medications are the platelet aggregation inhibitors. Okay, and this is like aspirin, Plavix. Okay, these are a little gentler for patients with not quite as many side effects. And then we talk about the direct thrombin inhibitors. These act a lot like Coumadin, but also try to stop the coagulation process. Okay, these are newer meds, and you'll probably give these a bit through your career. And some of the different meds are like Pradaxa is a thrombin inhibitor, and Xarelto, which inhibits activated clotting factors, keeps them from doing their job so that they don't let the blood clot. And the thing about these that people find, we find so much easier for compliance is patients don't need to have weekly blood work. Okay. And then the last category are the protease activated receptor 1 antagonists. So these are used in people who have had an MI or who have arterial disease, and they need to lower the risk of having another heart attack, stroke, or some sort of a cardiovascular death. Okay, these medications are a little bit more intense, and anybody who has any history of having a brain bleed or any type of a stroke or a bleeding disorder would be discouraged from taking these medications. So the actions and uses, well, preventing new thrombus formation, preventing somebody from making new clots. Okay, stopping existing clots from growing in size. And post-surgery, involving the heart or the circulatory system. Prophylactically, we would use these medications. Sometimes patients with heart valve disease and some dysrhythmias, for instance, I think you've probably all by now taken care of somebody with AFib and realized that they were on some sort of an anticoagulant. Because patients with AFib, the blood sits in the atrium a little bit more and tends to clot, and then the heart just pumps the clot out to the lungs. Patient has a PE or it goes to the brain and they have a stroke. Patients receiving hemodialysis. A lot of times patients are on anticoagulants to keep their fistula, their IV access, not their IV, excuse me, their dialysis access from clotting over. And patients on prolonged bed rest or with a history of thrombus formation. Okay? Patients who have a history of pulmonary embolisms when they are on a long flight are often given medication. Heparin is the drug of choice, though, when we need an immediate effect. And heparin can be given IV or sub-Q, and then to get the patient through the initial crisis, and then it's usually changed over to oral meds, like, for instance, Coumadin. The oral meds take 48 to 72 hours to really kick in and start being effective, so a lot of times we are starting the Coumadin as we are decreasing the heparin. Now, adverse reactions. Of course, the most common adverse reaction to all these medications is going to be bleeding. And early signs and symptoms, a lot of times really it starts with the gums bleeding when the patients brush their teeth, or all of a sudden they start having nosebleeds for no reason. Now with Coumadin, patients can lose some of their hair, alopecia, a rash, urticaria, cramping, diarrhea, intestinal obstruction, nausea, paralytic ileus, vomiting, excessive uterine bleeding, leukopenia, and fever. With heparin, patients can actually experience hypertension, headaches, a hematoma, conjunctivitis, tearing of the eyes, rhinitis, hemorrhage, thrombocytopenia, dyspnea, chills, fevers, alopecia, persistent or prolonged erection, hypersensitivity. Okay? And for drug interactions, again, remember the vitamin K and the Coumadin. Okay, you want patients on Coumadin to avoid vitamin K. Okay? And any patient who's on any anticoagulant who takes aspirin or any of the NSAIDs, the non-steroidal anti-inflammatory medications, is putting themselves at an increased risk of inappropriate bleeding. All right, now, so calculating the heparin dose, especially if you're giving it IV or, you know, an IV drip or an IV push, or just even flushing an IV line, you need to be really, really, really careful drawing up the dose of heparin. There's many different strengths of heparin. You know, some come with 10 units of heparin in a milliliter, and some come with 10,000. So you can make a big mistake with this if you're not careful, and it is one of those medications that we advise you to always have a second nurse check your dose. That's not so much for like giving somebody a sub-Q heparin that's in a prepackaged syringe, but if you are drawing up heparin, you really should, good practice is to have another nurse check your dose. Okay? And if you are giving someone like an IV dose of heparin, usually a loading dose would be like 80 units per kilogram as their loading dose, and then we would start at a heparin drip at 18 units per kilogram per hour. Okay? For monitoring blood values with Coumadin, we watch the PT and the INR. So PT, whatever normal is considered, you want the PT to be 1.5 to 2.5 times above normal. Whereas the INR, you want the INR to be 2 to 3. And that's for a patient who's on Coumadin. And a lot of times patients will get their blood drawn once a week, and then you'll have to call the provider every week with the results of their PT INR, and that will help them decide what their dose is going to be, if their dose is stable or if it needs to go up or down. And then heparin, we take a look at the PTT, and therapeutic is 2.5 to 3 times whatever the control value for that particular lab is. Okay. I hate to do this to you, but I'm going to back up to Coumadin for 1 more minute. If you're starting Coumadin, the normal dose is 2 to 5 milligrams, and it usually takes about 2 days before we see an effect in the INR blood work. So you would start someone at 2 to 5 milligrams and get blood work in 2 days, and it takes a little bit to figure out exactly what's the therapeutic dose for a patient, but that's how we go about it. So, nursing process. Well, a couple of things you're going to do. You're going to check for contraindications of an anticoagulant. For instance, alcohol abuse. We worry about patients who abuse alcohol having gastritis. And to give them, if they had any little bit of bleeding in their stomach that was inconsequential, then you're going to go ahead and give them an anticoagulant, and it'll become very consequential. Same thing for a patient who's known to have GI bleeds. A patient who has malignant hypertension. So malignant hypertension is usually a crisis situation, and these patients will come to the ER with a blood pressure of 190 over 120. And you're not going to give that patient an anticoagulant because you're worried about the risk of stroke. And a patient with a blood pressure that high, you're afraid they may, I don't want to say pop or explode. I don't want to say blow out. They may have a vessel in their brain burst. And if that vessel in their brain bursts and they're anticoagulated, they'll have a massive stroke. Okay. Other things to teach your patient is if they are having surgery or if they're having dental procedures, they need to consult with whoever it is that prescribed their anticoagulant to find out what they're going to do about that, because you can't go into the OR, an hour after you popped your Coumadin and think you're going to come out and not have bleeding trouble post-op. Okay? Here's some of the things we talk to patients about when we're doing patient and family teaching. We talk to them about taking these medications only as directed. Okay, we do not double doses if we miss a dose. If you realize you missed a dose, take it as soon as you realize it, but you're not going to take a double dose if you get to the next time you were supposed to take the medicine. Many oral anticoagulants only last 60 days after the bottle is opened, so patients need to be aware of that. Tablets should be swallowed whole without crushing them. Patients who are on anticoagulants should not take any other medications without checking with the healthcare provider, including aspirin or anything over the counter. Patients should wear a medical alert bracelet that states what it is they're taking. If a patient comes in and they've been in a car accident and they're unable to speak, to give their own medical history, maybe because they aren't responsive because they take a blood thinner and they've banged their head in the accident and now they've had a stroke. Or maybe they are internally bleeding from a wound that normally you wouldn't expect someone to bleed from massively, but if they're on an anticoagulant, yes. So patients should be wearing a medical alert bracelet, and they should let anyone who takes care of them, nurses, physicians, dentists, any healthcare providers, let them know that they do take anticoagulant therapy. Use caution in brushing teeth, trimming nails, and shaving. Teach patients how to put pressure on an accidental cut or scrape, and they should know that if they are still bleeding after 10 minutes, they probably need to seek some sort of medical assistance. Patients should not just suddenly stop taking any oral anticoagulants. This can cause a severe coagulation problem, cardiovascular or wherever. Patients should not engage in contact sports that would lead to injuries. Okay, your patient should not be taking Coumadin and then going out and playing tackle football or rugby. Patients should eat a normal balanced diet but avoid vitamin K. And again, they should really know how to check medications or know to notify their prescribers that they're taking an anticoagulant. Patients should avoid alcohol when taking anticoagulants. And they should know the side effects and what to do if they have a problem. Okay? Now, protamine sulfate. So here's the thing about protamine sulfate. It is a strong alkaline protein that neutralizes the effects of heparin. So what all those big words are saying is protamine sulfate is an antidote for heparin. So if someone was on a heparin drip and then we realized they were experiencing an overdose, we could give protamine sulfate. It acts almost immediately and stays active in the body for 2 hours. So if your patient was receiving heparin and then needed like emergency surgery right away, no stopping, let's go, 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 protamine sulfate would be the drug of choice to reverse that heparin. Sometimes they use heparin during a surgical case, but they don't want the patient to have the effects of heparin after the surgery. So they would give protamine sulfate at the end of the case, just to try to to decrease the effectiveness of the heparin that may still be on board. Adverse reactions to protamine sulfate include bradycardia, shortness of breath, weariness, hypotension, red flushing, and a feeling of warmth. Now, the action of thrombolytic agents. Thrombolytic agents, these guys are the clot busters. And what they do is they convert plasminogen to plasmin. Plasmin can break down clots, can break down fibrinogen and other plasma proteins. Okay, so this is used for like acute MI, acute pulmonary emboli, acute ischemic stroke, and acute arterial occlusion. These are the medications that break down clots. Now, if a patient comes in and you believe they're having a stroke, obviously they're going to have a CAT scan of the head first to make sure it's a thrombic stroke, not like a burst blood vessel. Okay, we try to give them within 12 hours of the signs and symptoms, and if it's less than 6 hours, we can actually use something called Activase. Okay, and Activase is a TPA, a tissue plasminogen activator. Okay, it was very exciting when these drugs first came out to be used, and yes, I was there. I had taken my horse to work that morning and parked it outside the hospital, but because I didn't have a car, the cars weren't invented yet. With patients who are receiving thrombolytic agents, we always are watching for adverse reactions and bleeding. These patients are in the ICU somewhere and they're monitored basically 1-to-1. We worry about bleeding, we worry about dysrhythmias, we worry about low blood pressure. Okay, we worry about a lot with these patients. We worry about a cholesterol embolism, hypersensitivity, a PE. Okay, and drug interactions, we don't give these drugs while we're giving other anticoagulants. And again, these medications are saved for usually critical situations, and they can break up a clot that has already formed. They won't, what am I trying to say? They won't prevent clots, but they can get rid of a clot that has already formed. Okay? And that, guys, is your education regarding hematologic agents.